Thank you, Alan, and thank you very much for inviting me along today. I'm absolutely delighted to be here. It's really important for me to be here because I think I'm new to the world of social care. I'm a long-standing person from the health service who's joined this new part that is health and social care integration. And for me, it's important that we begin to build, to develop, and to nurture the relationships across health and social care that will ensure that we absolutely fully meet the needs of those in our society who, at times, are the most vulnerable, but at all times should be the most valued. And hopefully today is a start for me to begin to build some of those relationships with folks in the room. I've been asked to talk a little bit about experiences in North Ayrshire, and the title that was given to me for the presentation was New Wine in Old Vessels. And that took me back to my student days, because I was not into old wine, but I was very much studying new public management theory, and that was one of the concepts that came through at the time. And I remember some not very positive connotations, so I've adapted, and I hope the organisers bear with me, I've adapted the question that was posed to me. And I'm questioning whether or not it is old wine in new vessels, or whether it is truly the paradigm shift we need to make a difference in health and social care as we go forward. And I hope it is. I think it is, and I hope I can convince you it is. I'm going to talk a little bit about what my experience has been like for the last 2 years in North Ayrshire, some of the opportunities we have, some of the challenges we face, the new model of care that we are looking to deliver, and crucially, the role for home care in delivering that. And there's always a risk, isn't there, when you come to an event like this, that you follow a renowned speaker like Bridget, and she might say something that's entirely at odds with what you're about to say. So I was sitting there very nervous at the start, but I'm delighted to say I think there are real echoes in terms of what you're going to hear from me now. Hopefully she hasn't stolen all my thunder, and I keep you with me along the way and you don't go nodding off. But if you do, I'll forgive you, it's fine. So, North Ayrshire. Almost 2 years ago, I was offered the job in North Ayrshire as Head of Health and Community Care. And this is the kind of image that I had available to me. It was a beautiful sunset over Arran, looking out of the Cunningham House windows across Irvine Bay. And it is a fantastic place to be. There's no getting away from that. It's a beautiful place to be. And I am surrounded by people from within health, social care, from within the independent social care side as well, and also from the third sector interface, who are, like me, highly motivated about doing the best we possibly can for the local people we're there to serve. But it's not all positives. There are some real challenges for us in North Ayrshire. And as you can see from a sample of stats that are up there, in terms of early mortality from coronary heart disease, cancer, and alcohol-related conditions, North Ayrshire is way above the Scottish average. And indeed, our worst locality in terms of experiencing those levels of mortality is at times 3 times higher than the Scottish average, particularly around coronary heart disease, and just over twice for cancer and alcohol-related conditions as well. So we have a sick population who we need to find a way to care for differently. The need to care for them differently is absolutely evident in terms of the number of emergency admissions that we see coming through. And again, our worst performing locality, we see individuals who experience incredibly high rates of emergency admission and readmission. And we know that if we look to the future and we take into account our population changes, we can expect by 2035, so only 19 years from now, we can expect to need an additional 398 acute beds to meet those needs. And that would be a complete disgrace. Because what I was brought into post for was to create viable alternatives to acute admission, to look at the opportunities that services such as home care can offer to safely and effectively and much more proactively care and support individuals to live at home or in a homely setting for as long as we possibly can. A much wiser man than I said that if you keep doing what you've always done, you're always going to get the same result. Okay, so we need to change. We absolutely need to change. And I genuinely believe that within North Ayrshire, our partnership is in a really strong position to change. We have, right from the outset, developed incredibly strong links with the independent and third sectors. Our Scottish Care representative and our TSI representative sat with us as we began to devise what our integration joint board would look like, the cultures and values that would underpin how we work together. They sat side by side with us and co-wrote our first strategic plan, and they take great pride in the vision that's been set out within that. They also were heavily involved in how we allocated our integrated care fund in the first year and took control over the ideas and innovations fund and commissioned services on our behalf to begin to deliver that strategic vision. And now they're working with us to develop new models of care, to create a new vision for older people and those with complex care needs that will truly change how we deliver care and support locally into the future. That future vision is absolutely one where individuals are much more proactively supported than they are just now, where they are absolutely in control of decision making around the type of care and support they need at any given time to live that long, healthy, safe and active life at home. Not just drawing on the services traditionally provided by health, social care, the independent and third sectors, but also networking out into local communities to make sure that we develop and build community resilience as well as personal resilience to support individuals into the future. Once more, putting people back into the heart of communities and ensuring people are valued by the local communities for what they can bring. In terms of the outcomes that we're looking to deliver through that, absolutely it is the person at the heart of decision making. As I've said, it is about a focus on prevention and early intervention to make sure that we understand how an individual's needs are changing at a very early stage and we respond positively to meet those needs as we go forward. It is about the home, I would say by and large, but also homely settings, but the home becoming the norm in terms of the facility within which all health and social care services are delivered. And it is about making sure, and I know you don't like the word integrated, Bridget, but it is about making sure we join up our services across all providers to make sure we offer consistency and continuity of care. I'm about to go to a really busy slide, so please bear with me. It is about focusing on the individual at home, as I say. It is about linking them with their communities, and it is about, for me, forming a new integrated team around those individuals. It's about making sure that that team comprises home care, social workers, district nurses, CPNs if that's necessary, certainly general practitioners, and crucially looking to move out some of the specialist services that have traditionally been delivered within acute hospitals locally, like care of the elderly services, and some of our elderly psychiatric services, and bringing those medics out to be part of that community-based integrated team, to make sure that they can rapidly access the equipment and adaptations, and make use of new technologies that are required to support individuals at home. To recognise that at times the needs of those individuals will be such that they'll require care within a different setting. And at that point in time, our integrated team becomes a liaison team. So absolutely reaching into care homes to provide care and support, as well as training and advice to the staff within care homes to meet those needs. But crucially, absolutely following their service users into the new front doors at our acute hospitals. We have new combined assessment units, and our vision is that those integrated teams will follow their service users into those facilities and will work with the specialist clinicians within the new combined assessment units to fully assess the individual's needs and, as a norm, bring them back home. If they require full acute care, they will follow them onto the acute wards, and again, they will act as equal partners within those acute ward settings to provide advice and support to the specialist services with a view to bringing people home. Absolutely linking as well with our community hospitals and with our rehabilitation services to make sure we have that holistic view of how we care for people and, crucially, make sure individuals remain as independent as they possibly can. We also recognise that there are some highly specialist elements of care that we need to deliver in a whole variety of settings. Absolutely, we need to be ensuring that we are dementia friendly in everything we do, and we recognise the need to create and develop within our integrated teams the skills and competencies required to provide the highest possible quality of palliative and end-of-life care. Looking after individuals from that point of diagnosis through their curative stage, into their palliative stage, and at end of life, and crucially as well, looking after their relatives after the end of life. So for me, it is about home care, absolutely the heart of all of that. And I'll share with you a personal story as to why home care is quite so important to me. And Helen MacArthur's sitting second row back, and she's heard this story before, and it always sends a wee bit of a shiver down my spine. So, my father in 1995 was diagnosed with an acoustic neuroma. He had a massive brain tumour, and there's no question in my mind that the two procedures 6 months apart in the Southern General, as it was, absolutely saved his life. But he was a shadow of the man that he had been. He had been very active, healthy individual who loved his job as an engineer and loved his pastime as a gardener. The two operations left him paralysed down his left-hand side, and he became withdrawn, insular, and genuinely a shadow of the man he had been. So the surgeons saved his life, but they left him in a wheelchair like that. Home care gave my father his life back. It was that laugh, that joke, that truly caring attitude of the carers who came into his home that brought him back out of his shell and brought him back to life. And we mustn't lose that. That, for me, is the essence of home care. It is the essence of caring, and it's about making sure that we protect that regardless of what else we do around innovation and development of our home care services. So what I'm just about to run through in terms of what I see as the future vision for home care within our model must be underpinned by that desire, that drive, and that commitment to care and to engage with the individual on a very personal level, to understand them, understand their needs, and bring the best out of them. So, linked to that, it is very much about tailoring what we do as in terms of our home care services. But it's about recognising that doing that in the future is being part of and an equal partner within that integrated team. So no more the hierarchy of district nurses expecting home care assistants to pick up particular jobs. It's about recognising the specialism that is home care itself and very much protecting that. It is, I think, about home care taking on a role around connecting people with their local communities. We've introduced in North Ayrshire 6 community connectors that are designed to understand how individuals could be best served by the local community and point them in the right direction towards those services that exist there. I think that's a fine temporary measure. I would argue, though, that everyone has a duty and a responsibility to be a community connector, and I think we need to see that introduced into our home care roles. Ooh, technology died there. It is, as Bridget said earlier on, it is absolutely about making sure we use technology to best effect, and I think there's a big question for me in terms of what does the future look like in terms of home care, and how can we plug home care in more effectively to new technology as it develops, and how can home care support the delivery of things like telehealth into the future. It is about making sure we have rapid access to the right equipment and the adaptations that folks need, and putting, for me, home care in charge of that. You are the guys who are going to see these service users day and daily. You'll understand how their needs are changing day and daily, and we need to make sure you have the resources at your fingertips to respond to that. It is absolutely about supporting rehabilitation. I've been out with our community rehabilitation teams into individuals' homes, and it's fantastic. But you know what, once a care plan's up and running, that should and could be part of home care's role in terms of maintaining that going forward. It is about developing those more specialist roles, as I said, around dementia care, and crucially about palliative and end-of-life care as well. So I think that there are many opportunities, and I think locally we've just scratched the surface. And the thing that struck me about the independent social care sector is the innovation, the fleetness of foot that you have. And I think you can be giving us a lot of feedback around how we can develop services in a different way into the future, and how we can make sure that fits with that wider model of care. It would never be a presentation from me if I didn't talk about toast. And it always gets a bit of a chuckle because folk think, what on earth is he going to talk about now? So one of my earliest experiences of home care actually was through the district nursing service in North Ayrshire. I went along to have a chat with them about our strategic plan, and right off the bat, they go, what's this integration all about? It's just the same old nonsense again, nothing's going to change. You know, we're fed up with it, blah, de blah, de blah. And so I tried to dig underneath that and understand what it was they were particularly frustrated around. And it boiled down to one particular example. And the particular example was a frustration from our district nursing teams of going to administer eye drops within individuals' homes. And who were they meeting coming out the door but the carers, who had just administered every other medication but not the eye drops. And so they said, well, why can't the carers do it? And I said, well, I don't know. I'm new to this game. I don't have a clue. But I know a woman who does, so I'll go and speak to Helen MacArthur, which I did. And Helen said, let me think about it. She said a few expletives first, and then she said, let me think about it. And she came back, with a plan, as Helen always does, that was about absolutely delivering that service. It was about making sure that we had the right training, the right supervision in place for the carers to get the service up and running. And I'm delighted to say that in North Ayrshire we now have an eye drop service being delivered by our carers. And that's fantastic. Why the toast? So, I then said a presentation, not dissimilar to this with local staff. There we go, we've delivered that. So, quid pro quo, district nurses, when you're in administering an insulin injection and somebody requires a wee snack to tide them over till lunchtime, gonna no phone our care at home service, gonna just make them a wee slice of toast while we're in there anyway. So, discussions ensued with the RCN in unison. Rumours spread that David Rowland was sending the district nurses in North Ayrshire out to provide a Meals on Wheels type service across North Ayrshire. But things have settled down. And I don't think we're quite at the stage yet of them making that slice of toast. But having been out and spent a lot of time with our district nurses, they now understand the need to work much more collaboratively and collegiately with other services. They absolutely are sighted on the needs of service users, and I think we'll have that first slice of toast popping in a toaster within the calendar year. I'm done. So I just got my 3-minute warning, and it's perfect timing for the last slide. And I suppose I'm posing it to you guys around any thoughts and questions. I've left my contact details up there, and they'll be on the pack that comes out with the slides, I'm sure, and I would be really keen to have conversations with everyone in the room if you want to have a conversation with me about what the future might hold and what the opportunities might be for us going forward, so please do contact me. I have been called back to Ayrshire to an urgent meeting, but Helen MacArthur will answer all your really difficult questions over coffee. I don't know why you're laughing, Anne-Margaret Black, because you've been involved in the models of care work as well. Anne-Margaret's my counterpart in East, and so she can answer questions from an East Ayrshire perspective. But I'll be around for the next wee while, but I will have to shoot off rather sharp, I'm afraid, so apologies for that. I had hoped to spend the whole day here. It's been fab. I hope it's a relationship we can build and nurture going forward, and good luck with the rest of the conference. Thank you.